Hi everyone, welcome to my channel. I'm Dr. Michele Persico and today I'm going to introduce you to a high-yield topic that I have found in the USMLE Step 1, Step 2 and Step 3, the genital ulcers. With no further ado, let's dive into it. So generally, the clinical scenario described in question stems will always be the same: a young male or female who is sexually active with multiple partners and that does not use condoms. Generally, the question will ask you to identify the etiology of the genital ulcers, which can be chlamydia, syphilis, Treponema pallidum, HSV-2, Klebsiella donovani, Haemophilus ducreyi, or reactive arthritis, which of course is not a microorganism, but it's another possible cause of genital ulcers. So the easiest way to solve these kind of questions, in my opinion, is by working through an elimination process. The first step is to identify in the question stem if the patient has a painful or painless genital ulcer. And if the genital ulcer is painful, of course, it can be HSV-2 or Haemophilus ducreyi. Whereas if the ulcer is painless, the four possible causes are chlamydia, Klebsiella, syphilis, and reactive arthritis. So a mnemonic to remember that Haemophilus ducreyi causes painful genital ulcers is the famous mnemonic Haemophilus ducreyi do cry. It's really easy to remember this way, that Haemophilus ducreyi causes painful genital ulcers. So in case the ulcer is painless, the second step is to understand if there is inguinal lymphadenopathy. If the inguinal lymphadenopathy is absent, 100% is Klebsiella donovani the answer. If there is inguinal lymphadenopathy mentioned in the vignette, it's most likely chlamydia or syphilis. And the mnemonic that I used for Klebsiella donovani is the word no within the word donovani. This was an easy way for me to remember that Klebsiella donovani did not cause inguinal lymphadenopathy during test day or during my USMLE prep. Now, if there is inguinal lymphadenopathy, actually there is a differential diagnosis that should be done between chlamydia and syphilis. And I had discussed in the next slide, so let's dive into it. Now, let's say that question stem shows that the patient had a certain point in time inguinal lymphadenopathy. In that case, of course, and the ulcer is painless. So in that case, it can't be Klebsiella donovani, it should be chlamydia or Treponema pallidum, or also reactive arthritis. So we'll discuss more about the reactive arthritis in the next slide. Now let's focus on chlamydia and Treponema pallidum. As you can see, once again, the way to make a differential diagnosis between these two etiologies is to focus on the inguinal lymphadenopathy characteristics. So let's say that the patient, for example, in the vignette had inguinal lymphadenopathy that's solved, and now there is just the painless genital ulcer. In that case, it can't be Treponema pallidum because, as you can see here, ulcer and lymphadenopathy coexist, but it's more likely that it is chlamydia. In this case, the question stem will show that the inguinal lymphadenopathy is painful and it's suppurative, which means that the lymph nodes will break and they will release pus. Whereas in case of Treponema pallidum, the inguinal lymphadenopathy is painless and there is no suppuration. Another important clue is the location. Generally, chlamydia, trachomatis, and the serotypes from L1 to L3 causes this kind of diseases, which is called lymphogranuloma venereum, which is more common in the tropical and subtropical region, and it's really rare in the US. Whereas Treponema pallidum, so syphilis, is more common in the US, which means that if you see that a patient traveled outside of the United States, it's more likely that it's chlamydia than Treponema pallidum. And so it's more likely basically lymphogranuloma venereum than syphilis. So the last possible cause of painless genital ulcer is reactive arthritis. So for reactive arthritis, the differential diagnosis, compared to the other microorganism is fairly simple. That's because there are other types of symptoms associated with the painless genital ulcer, and there is a specific presentation. So by specific presentation, I mean there is a gastrointestinal infection, and the gastrointestinal infection is caused by potential bugs like Campylobacter, E. coli, Salmonella, Chlamydia, or Yersinia. So remember the mnemonic SEXY to remember these bugs. And the potential symptoms are the typical triad of conjunctivitis, urethritis, and arthritis. And to remember these symptoms, you can remember the mnemonic can't pee, can't see, and can't climb a tree. There is also a specific scheme finding in reactive arthritis, which is, at least in the USMLE, found only in this kind of disease, which is called keratoderma blennorragicum. And it's basically a hyperkeratosis, which is mainly found in the palm and soles of your body. And if you have a patient with a painless genital ulcer that had gastrointestinal infection a couple of weeks ago and now has also eye pain, dysuria, or joint pain, it's most likely that it is reactive arthritis compared to the other potential infection by chlamydia, Treponema pallidum, or Klebsiella pneumoniae. So on the other hand of the spectrum, a potential genital ulcer can be painful. So if you read in the question stem that genital ulcer is painful, of course you have to think to different bugs than the one described before. We have HSV2 or Haemophilus ducreyi. Remember Haemophilus ducreyi or ducreyi to remember that it causes painful genital ulcers. So for HSV and ducreyi, the differential is based on the characteristics of the ulcer. So the ulcer base, the exudate, and the morphology, and the number of ulcers that you will read in the question stem will lead you to a certain differential diagnosis instead of another. So in HSV, the ulcer base is erythematous, whereas in ducreyi is grayish or necrotic, and ulcer exudate is purulent, and this is really an important buzzword for Haemophilus ducreyi. Just remember that in potential bacterial infection, the production of pus is possible, it's common, whereas in a viral infection is something that you generally don't find. The ulcer morphology for HSV is also characteristic because it's punched out. And about the number of ulcers, so for HSV and Haemophilus ducreyi, in both cases there can be multiple ulcers, but if there is just one ulcer described in the question stem, it can't be HSV, and it must be, in that case, by an elimination process, ducreyi. So guys, this is a flowchart that I have designed to give you a quick instant reminder of everything we have talked about. So the first thing you have to consider when you approach a question about genital ulcers in the USMLE is to understand or to read in the question stem if the ulcer is painful or painless. And after that, if it's painful, you have to focus on the features of the ulcers. So if it's erythematous punched out and there are multiple ulcers, it's most likely that it is HSV type 2. Whereas if it's grayish necrotic, the exudate is purulent, and if there are multiple or even more one ulcer, it's Haemophilus ducreyi. Whereas for the painless ulcers, you have to consider that the lymphadenopathy basically. So if there is no inguinal lymphadenopathy, it's more likely that is Klebsiella pneumoniae, whereas if it's inguinal lymphadenopathy, it's a differential between chlamydia and syphilis. In this case, you have to consider the characteristics of the lymphadenopathy once again. So if the ulcer disappears by the time the lymphadenopathy appears, it's most likely chlamydia, so lymphogranuloma venereum, especially if there is suppuration, so if there is release of pus from the enlarged lymph nodes. And if there is a coexistence between the ulcer and lymphadenopathy, it's most likely that is Treponema pallidum, so syphilis. If you see in the question stem that there has been a gastrointestinal infections and there are other systemic symptoms like joint pain, conjunctivitis or arthritis, so a suspect of a UTI, it's most likely that we are dealing with reactive arthritis. So sometimes, especially I would say in step 1, you will see some histological description in the question, sometimes in the question stem, most likely in the question stems, but less likely in among the answer choices. And the description you will find are about the histological characteristics of the bugs that are associated with the genital ulcers. So let's say for chlamydia, if you have, for example, a genital ulcer caused by chlamydia, there can be description on the histological section of intracitoplasmic bug and inclusion bodies. Whereas for Klebsiella donovani, you have the Donovan bodies, which are basically intracytoplasmic cysts that contain safety pin appearance of all bodies. You see here in the picture, this is the cyst, and inside there are these bodies which are safety pin-like. And for HSV type 2, you have multinucleated giant cells, which is a common histological finding that you will find frequently in the USMLE step 1 questions. And it's important to remember that there are inclusions that are eosinophilic and intranuclear. So the type of staining, so if it's eosinophilic or basophilic, and if it's intranuclear or intracytoplasmic, is important to distinguish from other viruses like cytomegalovirus or rhabdovirus, so the virus that causes rabies, or also in some cases you will find also description of inclusions about the JC virus, but in that case the patient is immunodepressed and it's easier the differential diagnosis. For Haemophilus ducreyi, you will have the characteristic buzzword of school of fish appearance. You'll see here that there are these bacteria that are lined up, one next to the other, adjacent to the other, and then they will have this characteristic histology finding. So for the ulcer morphology, we described the HSV and the Ducreyi, and so you check the previous slide for that. But for Klebsiella, sometimes you find the macroscopic morphological description of vascular beefy red ulcers with elevated rolled margins, and this is another way to kind of confirm that a painless genital ulcers with no inguinal lymphadenopathy is caused by Klebsiella donovani and no other bugs. So guys, now let's dive into a question to solidify everything that I told you about before on genital ulcers. So I will read the question stem. Feel free to pause the video for a couple of seconds to try the answer yourself. And after I read the question stem and the answer choices, I will give you the explanations on how to approach these genital ulcer questions that you can find in the USMLE. So a 22 years old Caucasian female comes to your office for a routine checkup. She's in grad school and works part-time in a nightclub as a bartender. On her sexual history, she had 4 sexual partners in the last 6 months. She had a copper intrauterine device placed 1 year ago. She feels well and is otherwise asymptomatic. At inspection, there are 3 small lesions in her labia which are not tender to touch. Which of the following microorganisms is the most likely cause of this patient's skin findings? A. Treponema pallidum, B. Chlamydia trachomatis, Serovar L1 to L3, C. Haemophilus ducreyi, D. Klebsiella donovani, and E. HSV type 2. Let's pause the video for a couple of seconds if you want to try to answer. Okay, so now let's go into the explanation. So this question has many different clues that can push you towards the understanding that this is a genital ulcer question. So first of all, this female has 4 sexual partners and she has a copper IUD in place. This is an indirect and a smart way for question writers to trick you, and because there is no mentioning of not using condom or other barrier contraceptive methods, but you can indirectly infer that the patient is not using them because she has another contraceptive method in place, which is a copper IUD. So the biggest buzzword that tells you that in this question that the patient has a genital ulcer is that at inspection there are 3 lesions in her labia, which are most likely genital ulcers, considering her sexual history, which is high risk for an STI, so sexual transmitted infection. Now, that you have understood that this is a genital ulcer question, the first step in order to reach the conclusion, so the right answer, is to proceed through an elimination process. And the first step of this elimination process is to understand if this patient has a painless or painful genital ulcer. This is step one, and this is the most important step in approaching and solving genital ulcer questions. So this patient is otherwise asymptomatic, and the lesions in the labia are not tender to touch. This should lead you towards a painless genital ulcer, not towards a painful genital ulcer. And bear in mind that when you read tenderness, this is a feature of the palpation, not inspection. But anyway, if you read tender, which means painful. If you read not tender, it means that the lesion is not painful. Anyway, so this is the first step. So you understood that the lesion in this patient is painless, and now you have to think about the workup for a painless genital ulcer and to remember the differential diagnosis. As you remember, the potential differential diagnosis for a painless genital ulcers are Klebsiella donovani, chlamydia syphilis, and reactive arthritis. Of course, among these answer choices, you don't have reactive arthritis, but if you had reactive arthritis, it's easy to rule out because there is no mentioning of gastrointestinal infections, there is no dysuria, there is no joint pain or eye pain, so it's less likely that it's reactive arthritis. Anyway, you don't have it in your answer choices, so you have to focus on mainly microorganisms. So in this question that I have prepared to you, so the lesion is painless. So my question is, in your opinion, which microorganism you should cross out? That's right. So if you crossed out Haemophilus ducreyi and HSV type 2, you're completely right. They cause painful genital ulcers, and they never cause painless genital ulcers, so they are definitely not the answer choices in this question. Now that you have ruled out the first two answer choices, you have to deal with the rest of the three. And so you have to think about step 2 in your differential diagnosis. And remember that if you are dealing with painless genital ulcers, the next clinical finding that you have to think about, which should be like imprinted in your mind to answer this question, is linguinal lymphadenopathy. If you said linguinal lymphadenopathy, you are correct. So linguinal lymphadenopathy is the type of clinical finding you have to consider. And the first step you have to keep in mind is that if the question Sam mentioned that at a certain point in time there was enlargement of the inguinal lymph nodes or not. And if there is no enlargement of the inguinal lymph nodes, is Klebsiella donovani, whereas if there is enlargement of the inguinal lymph nodes, is Chlamydia trachomatis or Treponema pallidum. So considering this, you know that in this question you can cross out as next step which of the following microorganism between Treponema, Chlamydia, and Klebsiella. So if you crossed out Klebsiella donovani, you are completely right. This is the wrong answer choice, and that's because Klebsiella donovani does not cause inguinal lymphadenopathy. And as you can see here, lymph nodes are enlarged in the inguinal area, so it can't be Klebsiella donovani. Now you have a 50-50 situation with Treponema pallidum on one hand and Chlamydia trachomatis on the other hand. You have to think about the characteristics of the Treponema pallidum inguinal lesions and Chlamydia trachomatis inguinal lesions. And once again, the key word, the buzzword, is inguinal lymphadenopathy. That's because, as you can remember from before, from the previous slides, in the in the Treponema pallidum, generally the lymph nodes are large and coexist with the genital ulcers, whereas in Chlamydia trachomatis, so in the lymphogranuloma venereum, generally you have the ulcers and the lymphadenopathy that do not coexist, which means that In this question, it's pretty clear which one of the answer choices you have to cross out. Try to guess which one of these is the answer choices that you have to cross out. I'll give you a couple of seconds. So, if you crossed out Chlamydia trachomatis and answered Treponema pallidum, you are 100% correct. Congratulations, you answered this question correctly, and I think you are also in a strong position to answer all the potential questions on genital ulcer that you will find on test day or during your USMLE prep correctly. I would like to leave you at the end of this video with another tip about genital ulcers. This is more like a nuance that you can find on test day or during your USMLE prep. So sometimes, although the answer can be Treponema pallidum, the question writer won't show the inguinal lymphadenopathy in the vignette. So a possible question you can ask is, if Klebsiella donovani does not cause inguinal lymphadenopathy, how can we differentiate between the Treponema pallidum genital ulcers and the Klebsiella donovani genital ulcer? And my answer is that in my experience, I have never found Treponema pallidum and Klebsiella donovani among the same answer choices if the question writers does not describe inguinal lymphadenopathy in the question stem. So once again, if the question stem does not show inguinal lymphadenopathy, or there is no clue that the patient had a large inguinal lymph node, of course you assume that there is no inguinal lymphadenopathy, but there will be or Treponema pallidum in the question stem or Klebsiella donovani in the question stem, but not both. And this can be, of course, this is to make your life easier and to kind of answer the choice without any confusion. So guys, this is everything that I have on genital ulcers. Thank you so much for watching, and I hope this was helpful for your preparation. Please drop a like if you enjoyed my video and follow my channel for more content. I will try to post a couple of videos per week on my USMLE experience and my journey towards residency. See ya!